So what I'd like to do over the next several minutes is to provide a presentation. I know there may be a somewhat heterogeneous group who have quite a number of participants. Some may be have never tried Tenex. Some may be experienced users wanting to know what's going on with regard to updates, and some may be in between. So hopefully what we say over the next several minutes will be of some value to whatever state you might be in referable to your experience with Tenex. It's probably pretty well recognized by those in attendance. Tendinopathy is a relatively large problem with regard to just the burden of disease in our society. Several years ago, over 30 million codes were recognized, not just a tendinopathy, but a chronic tendinopathy. And as is recognized, this can occur upper, lower, and even around the truncal extremities. So it's a major problem in society and also has a major burden with regard to the anatomic distributions. Most of the problems are seen around the elbow and the shoulder and the upper extremity, and the foot and ankle lower extremity. Although the gluteus medius is a unique problem in that it's maybe not quite as common, but there's no really good solution for this. And I think one of the things that I would like to share and kind of emphasize is we feel as though our technology and our treatment option is particularly good in those areas in which there's considered no good viable alternatives. Just a word about the pathophysiology. I suspect most people are pretty familiar with this in one way or another, but it's actually fairly complex. There's over 10,000 publications in the last 8 years just on tendinopathy, its etiology and treatment. But the chronic refractory tendinopathy starts with some kind of an insult that results in a neurovascular mediation. And then there's a reparative signal that is sent to the brain. And this is where things get a little bit interesting, because in the majority of patients, that reparative signal is effective and will result in the various stages of the disease, ultimately resulting in healing. However, in some instances, this reparative signal appears to be lost or ineffective. And in that instance, we are left with a condition that we would call chronic refractory disease. And it's that patient that we feel is particularly amenable to our treatment option. And until recently, for your information, if you didn't know, if you review the literature, there was no accurate definition of a chronic refractory tendinopathy, just speculation and arbitrary temporal definitions. When I was in training and teaching residents on a regular basis, we said 12 months is the cutoff. If they're no better in 12 months or still having problems, we're willing to operate. Well, this study at the Mayo Clinic covered a 10-year period, over 2,000 elbows, and we found that, in fact, 80% of the patients did do well and did not require any additional treatment after 6 months. However, and what was not recognized in the literature until this paper came out, if you were that 20% that were still having significant symptoms at 6 months, the average time to healing was more than 2 years. So you were in for it. Not only that, if you had resolved at 6 months and you followed these patients, a full 15%, 1 out of every 6, would recur. And so it's a very daunting data that says chronic refractory tendinopathy is common. It's difficult to resolve once it gets established, so to speak. And if it resolves spontaneously early, you may still have a chance of having a recurrence in the course of your activity. So what are the treatments? Well, in the early stages, in that 3 to 6 month period, eccentric exercises are really the cornerstone of treatment. And for your information, there is science that supports eccentric exercises as primarily evoking a stimulated response for healing. In other words, it stimulates a healing response. However, it varies with different sites. The elbow is more effective, say, than the Achilles. It is safe, it's prolonged, it's uncertain. The costs are variable depending upon whether it's supervised or not supervised. Everybody knows that the cortisone has kind of been the standard, particularly for the acute hot disease that is keeping people from working in the early stages. However, studies in the last several years have been bothersome in that this randomized control study by Coombs in JAMA, 165 patients, fairly significant study, followed a year, demonstrated that eccentric exercises were as good as steroids, but in fact, steroids at 1 year were worse than eccentric exercises. In a review of the literature for consensus of randomized controlled studies, 7 of those by Hart in 2011 demonstrated that cortisone was about the same as doing nothing and about the same as physical therapy at a year, and then at 12 weeks and then at a year. So these studies have put a very significant, have had a significant input on the options that a clinician has to treat the early and intermediate stages. That is, cortisone, at least in my practice, is no longer an option. So what's the indications for this process or this intervention? When do we intervene? Well, the curve on the left is the first part of the curve that I showed on that Mayo study. And so what we do is we assess at 3 months. And if they're down here not making any progress, then the likelihood of them following the curve that goes straight up in the next 3 months is about 0. They will follow a trajectory somewhere around in here, and certainly by 6 months, they're not going to be anywhere close to healing. If they're following a fairly steep course and seem to be making progress, then those patients are ones that we would allow to continue to see if they will resolve spontaneously. So we actually have our first testing period, so to speak, at 3 months. And if poor progress is being made, I will start asking whether or not they're interested in some definitive treatment. And I do that because of the risk-benefit ratio that this particular treatment has exhibited. So this is the key concept in a chronic refractory tendinopathy and what the tests are, so to speak, to decide whether or not to offer intervention. So what would be the ideal intervention if you're not going to let time take care of it? Well, you'd like to definitively treat. You'd like to do it early, or at least as soon as you know they're not going to get any better on their own. If you intervene, you'd like to make sure that they actually did recover and recover quickly. You would like for it not to be costly either to the society by having people being off work or to the healthcare industry having to pay a lot of money for the intervention. And ideally, you like to have virtually no risk, which are impossible. So you like to have a very, very minimum risk. So in mathematic terms, what you're looking for is an optimization of both the risk-benefit ratio and the cost-effectiveness ratios. And if you can do that, then you have an effective treatment that is one that patients will request when needed, and you would feel proud to be able to execute. So what are the procedural interventions that you can offer a person that gets into this category of chronic refractory tendinopathy? Well, there are several that have been shown to be somewhat effective. Dry needling, various biologics, that is PRP and stem cells, and then formal surgical procedures. Dry needling is kind of interesting because this is a little bit like what we do with the Tenex procedure, but what it doesn't do is it doesn't remove the pathology, and it doesn't do anything other than irritate the locale of the problem, but it seems to be pretty effective, and it does seem to stimulate a healing response. So that says that any kind of formal mechanical intervention may be effective, which is important information. But again, this doesn't remove tissue, so the rapidity of resolution is not as rapid as if you had removed the disease. But what about PRP? I suspect many people on the call are using PRP or have used it, and it's a very interesting phenomenon in a way. There's tremendous research being done on it. There's tremendous competition to find the optimum method of producing this and the optimum time to deliver it. But unfortunately, some of the literature is not as strong as you would like. A meta-analysis done now several years ago showed no proof of efficacy. That doesn't mean that it's not effective. It just means that the studies done to demonstrate efficacy simply weren't of sufficient sophistication or power to show a difference. However, there have been more recent studies that did show that PRP was more effective than untreated controls. That have been these studies being done in the more recent years. But it is done primarily because it's even though it's out of pocket, it's safe because it's the patient's own blood. And even before there was much data that showed how effective it was still being used because it was safe. So that's an important thing to keep in mind. The feature of a treatment that trumps all other variables is really the safety factor. And that's important to keep in mind, I think. So a more recent Cochrane report of the summary of the literature indicated interesting choice of words, may provide some benefit with lateral epicondylitis, but it's inconsistent for all these other anatomic sites. So the scientific data to justify its use exists, but it's very limited. Nonetheless, it is still being used, and its use is probably growing. What about stem cells? We've heard a lot about this. You may be surprised to know that as of 2017, just last year, in spite of all the, you might say, the hype over stem cells, there were only 4 studies that really were able to be used to determine its efficacy. And they're all level 4 studies, which means they're not that sophisticated, or they don't have an effective randomized control as a part of the study. 2 rotator cuffs, patella, and epicondylitis. They all show significant improvement. So you would say, well, this doesn't. But according to the Cochrane analysis, they reported these 4 studies as showing no evidence of efficacy because there was inherent bias in the study. They thought the level of study was too low to provide support for their findings. And it's a good example of why randomized controlled studies are very, very difficult in the sense that they are costly, they take a long period of time, and even when completed and published, they can still be criticized because of, you might say, technicality inadequacies. What about surgery? Once again, using the Cochrane, which is kind of the gold standard for level of evidence and efficacy, several years ago said, of all things, there's not enough information to tell us if surgery would make a difference in the quality of life compared to not having surgery. So if you're looking at the high-level scientific data, much of this, almost all of this, calls to question whether or not these various modalities are effective. But the clinicians will recognize they are effective because we take care of patients, and we have patients telling us that they had relief of their pain after the surgery or after the intervention. They did show in this particular analysis that any percutaneous treatment tended to be more effective than the more aggressive open procedures. And that, I think, is important when we talk about the technology that we're going to be talking about, and that is percutaneous ultrasonic tenotomy. So this is a procedural intervention, and it fits in with these other modalities similar to the dry needling biologic, which are all percutaneous needle type of approaches. And you should know, if you don't, or it'd be interesting to know maybe, that the predicate for getting FDA approval was this phacoemulsification, which is the technical term for cataract treatment using an ultrasonic probe. And this changed the treatment paradigm from lens replacement to cataract management by emulsification and extraction as an outpatient procedure under local anesthesia. Dramatic change. And this, as it turns out, was the predicate for the Tenex proposition of being substantially equivalent, which was accepted by the FDA. And I've been a consultant to the FDA for 15 years, and I have never seen an orthopedic device using a non-orthopedic predicate. So this I find interesting in its own right. So what is this device? Those that have used it are familiar, but those that haven't, maybe less so. It's actually a hollow probe. The probe is actually a needle. It's hypodermic needle, 18 gauge, but it's covered by a sheath, and the sheath emits irrigation solution that keeps the tip cool to avoid heat damage. And the probe generates or transmits the ultrasonic energy, and it's hollow. So as the ultrasonic energy cuts the diseased tissue, the disease tissue then is extracted from the wound by suction or vacuum on the probe. And you can see on the lower right the debris that's in the collection bag. So this last step makes this truly a very, very unique intervention, because it's similar to surgery in terms of cutting the diseased tissue and removing the diseased tissue, and it's similar to cortisone injection because it's just a percutaneous treatment. So it does remove the degenerative tissue, and therefore it lessens the impact of the disease, the stage of the disease, meaning when you're done, this patient is not in an acute, an intermediate, or a healing stage. They're all in a stimulated healing stage because you've gotten rid of the diseased tissue. There's a system console, and this delivers the optimized ultrasonic energy that does cut the diseased tissue. And this energy is such that it also spares normal tissue. So here's a demonstration we did at Mayo several years ago. Here you can see a normal tendon bundle histologically. You can see the collagen fibrils are in continuity. And we put the probe for 7 seconds on the tissue, and you can see that the tissue, quote, saw the energy because it's a little bit wavy, but there's no fractured bundles. There's been no cutting of this normal tendon. And then just recently, a couple of months ago, we returned to the lab and we did a 1-minute dissection where we laid the probe on collagen bundles for 60 seconds. And here you see the higher powers, different staining technique. You can see those bundles definitely saw something because they're very wavy, but you can also appreciate, I think, that they're not cut. So further demonstration that this energy at this level makes it extremely difficult to damage normal tendon, but it's very effective against a diseased tissue. And this is the animal study that shows this. This is a diseased tissue in the disease model. And you can see the track of the probe and how it was able to not only cut and fragment, but to remove the diseased tissue. And not only that, as we measured the structural collagens, collagen 1 and 3, we found that in fact they were altered after the treatment, but they returned to normal in about 3 weeks. So this study is very important because it demonstrates, yes, that the probe does remove and creates a void of the diseased tissue, but it also seems to stimulate a healing response that possibly accelerates the healing as early as 3 weeks, at least in the experimental animal. So what do we expect in the human being? Well, the disease, the response curve rather, is interesting, and it's kind of stylized here. And we would say that you should expect your patients about 80% of the time to be essentially pain-free or very, very near pain-free by 2 months, maybe 3 months. Some will respond very rapidly, and I've had a few patients that will go even up to 6 months, but after 6 months, they seem to be asymptomatic. So they don't necessarily have an instantaneous response, although a few seem to. You should indicate that it takes 2 to 3 months for the majority of patients to see the full benefit. So we've done at the end of last year over 75,000. We're about 78,000 now. And this, the distribution is, you can see the majority are the elbow, medial and lateral, and then plantar fascia is the second major use. What's growing most rapidly of these are the shoulder and the gluteus, and that's largely because the introduction of a new, probe. It is longer and allows us to reach these anatomic sites. Remember earlier I said that the real key is what is the complications, what is the risk. And in the first 75,000, we had 14 reported cases that I'm aware of. And this goes through our facility compliance and complaint department, so they get all the problems that have been reported, particularly those that have required any additional treatment. So there's been 14 instances where additional medical management has been required, and that includes 3 tendon ruptures. One of the patients was on fluoroquinolone, 2 infections, a nerve injury. The real problem, as many on the conference might recognize, has been a breakage of the probe. Usually this is not a problem. You pull the instrument out and you see the broken probe and you remove it. But These will sometimes occur around the hip area, and if that's the case, the probe may be left in the hip, and these are principally the ones that have required an additional procedure, local anesthesia, extending the incision and going down and retrieving the probe usually. So we would say, in spite of the issue with regard to the broken probe, the overall complication rate that requires additional intervention or attention is quite low. So what's the response? What's the outcome? This is probably our best study is from Singapore. 20 patients followed for a year at this point, and then all 20 were followed for 3 years. And both studies were published in the American Journal of Sports Medicine, which has the highest impact factor of any musculoskeletal journal. Very hard to get a publication. And the group from Singapore got 2 publications showing the definitive outcome of the visual analog score of pain, which was essentially 0 by a year. See how it comes down similar to the curve I showed. And then also the DASH score. They also did ultrasound follow-up, which is particularly interesting. Here you see a fairly large diseased area, and here you see the 5-year outcome looking like a normal tendon. And the group has just informed me that they've lost 1 person, I think, left Singapore, but they have 19, and they're starting a 7-year update study that is underway. Very quick review of what's in the literature. This is in the peer-reviewed literature. These usually are case studies. The animal study is shown here. Epicondylized by Co. I just mentioned the Singapore study. Here's a study from the Mayo Clinic by Barnes, who had 20 patients roughly, about 88% success at a year. That includes medial epicondylitis, which is an important contribution of that study. Patella tendinopathy, Stowers, team doctor for Florida State, had complete success in these 10. He's now reported that 14 patients are pain-free. Curlin Job Clinic in Southern California, Neil Elatrage and Steve Yoon, along with one of their fellows, reported 85% in patella tendinopathy success. So you can see this can be a very tricky disease, as many would know, and quite good outcomes. Achilles insertionitis, a podiatry group in Phoenix, over 90% success. Plantar fasciitis, interventional radiology group in Nebraska, had 100 patients, over 90% at 12 months. And there's an orthopedic surgeon in Indiana who reported 12 out of 12 patients had a good result with plantar fasciitis. What's of some interest in that last study is that 3 of these had open surgical procedures that failed, and they responded to the Tenex. And then finally, just recently, last month, Dr. Champ Baker, whom some of you may know or heard of, reported a sample of his own patients who underwent gluteal tendinopathy treatment, followed for 12 months, and with over an 85% success rate. So these various anatomic parts from various investigators and from various specialty training, those are all important kind of qualifications, have demonstrated quite good outcomes. So this is an important slide in my mind because it shows that we've had over 30 publications regarding Tenex in the space of only about 5 years, which is actually, I think, pretty good. And it shows that we have something on virtually every anatomic site, except we're working on the shoulder, and that's the most recent application. It's only since late 2015 that we started treating the shoulder. But you can see the other areas that we've got at least some comment in the literature regarding either the technique or the outcome. And we have 4 that are in preparation or in review. So it gives you some idea that not only have we got some information clinically, it's also being contributed by virtually all of the specialties that deal or that use the procedure. One of the last things I wanted to mention is just this cost effectiveness. We talked about how that would be treatment nirvana. And if you look at this analysis, if you take workers' compensation and you compare conservative treatment and then intervene with Tenex at, say, 3 months, that analysis shows that we save almost $9,000. And if you are able to avoid a surgical procedure, the saving is over $25,000. So from a workers' compensation perspective, the confidence to intervene early and the confidence that these patients are going to get back to work are, I think, very attractive features in the treatment. So here's one kind of addition to the regimen of the TX2, introduced in September of 2015, and it expanded the indication, as I've implied a little bit, to the shoulder and the gluteus. But for the orthopedic surgeons and for the not so much the non-op sports guys, but those that are less familiar with ultrasound, it also facilitates the technique, and I'll show that in a second. But this TX2 does, it's a longer probe, so it allows us to reach deep tissues, which are dense tissues. And so this increased the stress on the probe. And we had some moderately significant probe breakage that certainly exceeded 2% that we've actually documented. And I know in the field it was considerably higher. We have very aggressively pursued the analysis of failure and posited 3 solutions, 2 engineering solution and 1 supplier solution. And we now have our breakage rate under 0.5%. We're shooting for under 0.3%, and I think that we will get there, and we're on target to get there. So I think we have solved that problem if you've experienced it in your own practice, but you should still be very vigilant when you take the probe out. Always look to make sure that it's not just the sleeve you're removing, but you've actually removed the hypodermic needle type of probe. And here's why it's easier. With a TX1, depending upon the nature of your ultrasound sensor, oftentimes you'd have to make the puncture, and then the probe would enter the puncture site, and then the sensor would be over the probe, and that makes it hard to see, and it's awkward. With TX2, in almost all instances, you can make your puncture site outside the footprint of the sensor. And again, if you're a little bit less experienced, that certainly increases the ease in which you can learn and use ultrasound guidance. And here's an example of a calcific tendinopathy. And we think that it'll also work for biceps and AC, but we're beginning to study it specifically on this interstitial cuff tears, the intrasubstance tears, which is such a problem that the shoulder surgeons would appreciate. So in summary, we would say that the TX Health system, TX1, TX2 MicroTips, are percutaneous treatments that are similar to zone injection, but they have the efficacy of surgery and without the cost and morbidity. That, I think, summarizes our whole case, so to speak, in just a couple of words. And just one word in closing with regard to technique. This is very important to me because I hear that, well, we just don't do ultrasound. We're not ultrasonographers. Well, I'm not an ultrasonographer. In fact, I'm not all that excited about it. But I am able to find the pathology with ultrasound. And what I do on my, and I've treated all the anatomic areas we've talked about. I ask for the site of maximum tenderness, and I make an X. And then I put my probe or my sensor right over the X. And then you virtually 100% of the time will see the anatomic area you want. And with a little bit of movement of that sensor, you will see the pathology. So you don't need to be an expert in ultrasound diagnosis to put the sensor over the X and find a bone and a tendon that are immediately under the skin. The only exception to the deep tissue really is maybe plantar fascia, which is still easy to see, and the gluteus, which is really not that hard to see either. So my point is, it's not all that hard. And in fact, the point that I've often made is that if you blow up the image, you can't tell what anatomic part it is, meaning that if you've learned how to examine for the elbow, you can find all the other areas similarly. So this is a slide that I think proves that. So if I gave you a quiz, these are 6 images and they represent 4 different anatomic sites. Can you tell me which is which? Which is the elbow? Well, it's this one. Well, I'll be darned, it's this one. And which is the Achilles? That would be this one. What about the jumper's knee? The jumper's knee, I don't know. Maybe this? No. Yes, this one and this one. So what's this? Plantar fasciitis. So if you blow them up enough, you can't hardly tell what you're looking at. So you get one anatomic area down, you've got them all down, in my opinion. So the technique, you find the X, you anesthetize it, you make a little stab wound. I make a deep stab wound. I like to go all the way to the bone to make it easy to get my probe in. Here's a TX1. You can see how it lifts up the sensor, making it a little bit more difficult. And there's the probe going into the hypoechoic blackened area. And we use an amplitude of about 3 to 5 millimeters to treat the lesion. You don't go out of plane. It's linear, back and forth. And stereostrips closes it, so it's pretty straightforward. So the technique is the clinical exam, mark the spot, confirm the lesion with ultrasound, prep and drape like a steroid. Local anesthesia, I go to bone and I kind of tap the bone. It's kind of like dry needling. I incise the skin and fascia. The probe back and forth, as I mentioned, 3 to 5 millimeters. Usually the hypoechoic, not usually, the black and hypoechoic area will turn white when treatment is complete. And you also feel kind of a void because you're removing tissue. The final clue to completeness is I look at the timer on the machine. And for example, my rules of thumb, so to speak, just typically an elbow will take 60 seconds, rarely more than 80 or 90 seconds. Plantar fascia, typically 90 to 2 minutes, rarely more than that for me. I know a lot of people go longer. The treatment time, as I mentioned, is between 1 and 3 minutes, depending upon the anatomy. The recovery, ice and Tylenol. I have them rest for 3 days and then sedentary activity for 3 weeks. Resumption of normal activity up to 6 weeks. And then that. And I double it for jumper sneeze. I typically don't use adjuncts. I don't send them to therapy. If it's an Achilles or an insertionitis or maybe a plantar fasciitis, if they have a boot, I'll put them back in the boot until they don't think they need it. And then we follow them up at 1 to 3 weeks, 1 to 3 months, and then 6 months final. And sometimes because I'm in and out of San Antonio, people will call me for their follow-up instead of me seeing them. There are issues with regard to reimbursement, and I'm going to defer at the moment and try to answer that by taking questions. We do have our company expert, John Holder, who's been hired for and has worked very hard in understanding and optimizing our reimbursement recommendations. So we'll be happy to take any questions regarding that issue, which we know is a real one for you. And so with that, thanks for your attention. And if you do have questions after the webinar, and the webinar will be made available to you, the copy of this, this is the contact that you can contact the corporate office and get any kind of help you may need. So with that, I'll stop and would be more than happy to try to answer any of your questions. What few lessons you learned about Tenex that I could use to be more successful for my patients with other tendinopathies that I have been less successful treating? Maybe this might be something that we ought to talk about specifically, because it sounds like it's a somewhat specific question. But if others out there are saying, yeah, I wanted the same thing. I remember we went to one physician training session, and everybody was talking about their great results. One guy steps says, my results aren't all that good. And I thought, I wonder how often that really happens, but people just don't want to admit it. And so I think this is a very good question, and it's real. The first thing to do is talk about patient selection. There's two types of patients. There's a patient that is in the sweet spot. They're the people that have the ideal symptoms, the ideal findings, the ideal time period, the ideal personality. So they're going to tend to do well. And then there's people that have more vague symptoms. They have some features that are consistent with the tendinopathy, maybe not perfectly. And I offer different potential outcomes. The sweet spot, I say, is about 80%, and I think it's about 90%. The ones that I'm not quite sure are more vague, I just say it's 50-50. But it's safer and faster and easier and less morbidity than any other option. So I tend to offer it. Go through the steps of making sure you know where they're locally tender, making sure you're treating in exactly the right place, making sure that the post-procedure period, the patient is following your advice. Those are what I'd say the tips. But if that wasn't a very good answer for you, give me a call, and you can find me through this info at Tenex, and I'll be happy to discuss the details. The first thing that makes an appropriate treatment option is your other alternatives aren't so hot. Right now, one of the most common ways of treating this is arthroscopic for the orthopedic surgeon. And there's still some morbidity with that. And it takes a while. It's not as elegant as Tenex. And it's much more costly. If you're not a surgeon, if you're not op sports, then you just have to needle that thing till you're blue in the face. And the Tenex energy just facilitates that, makes it go faster. I'm not quite sure you really have to remove every last evidence of the calcific tendonitis. If you break it up so that it's just small little spicules, these tend to get resorbed. But I think, and there's no size limit. I will say that if it's more of a pasty, less mature, less dense, less hard calcific deposit, it's much easier to remove, just as you might imagine. But even if it takes a while with Tenex, and it can take 7-8 minutes, that's still faster than putting them under and doing an arthroscopic procedure. Many people show coming into the plantar fascia from a medial approach, out of plane. The dictation template seems to support that. But I like doing ultrasound guided tibial nerve block and then doing the procedure in plane and dictating according to what I do. But is there a reimbursement issue with that? Not that I'm aware of. John might add, but you should do what you're comfortable doing. I did foot surgery 7 years. I was in the Mayo foot clinic for 7 years. And if you're just using local, well, patients just do not tolerate that at plantar, as you know. So that's why I go medial, and I really like that. It's very little morbidity. But if you're going to do it your way, you do get the reimbursement of the block. I don't think there's any additional reimbursement at all. It's still going to be a percutaneous partial plantar fasciotomy or plantar fasciectomy. And the code should be the same regardless of the approach. John, do you have any additional comment or variation in your opinion?
No, the approach is no different from a reimbursement perspective. It just depends on the clinical documentation of ectomy versus otomy. So some of the codes in the foot and toe are ectomy, fasciectomy, as opposed to others which are fasciotomy. So clinical documentation and the procedure performed will define which code to use.
Good, thanks. If you have additional questions, again, just contact us. Why interstitial tears only? Why not articular or bursal side? Actually, to be candid, it isn't just interstitial. There is debate, as you probably know, in orthopedic circles of how do you treat these interstitial tears, substance tears, partial tears, incomplete tears. And when you're talking about partial or incomplete, often that is referring to either a bursal side or articular sided tear. There's no good treatment right now for any of those variations. And we think the reason this might work out is it doesn't take out any of the normal tendon to speak of, and it might stimulate a healing response. I do think articular are different than bursal sided tears, and substance are different yet, just because the healing environment is different. But we don't have enough experience to really say one works better than the other, except I will say this. There is no other treatment that has a chance to be definitive, that has less morbidity, it's done under local anesthesia, and it still has a chance because of the rationale of treatment to actually stimulate healing. So I think of all the extracorporeal shockwave has also been used and it's shown some response. So I think this is much better than what most people are doing, either observing and then worrying about it expanding or progressing, or going in arthroscopically. And these have morbidity to them, and it takes out normal tissue in the process of doing the debridement. So it just makes sense to try this on that whole category of tears, the incomplete tears. Thoughts on using it in smaller tendons, FHL and dancers, since they often get tendinopathy. I haven't used it in those settings, but others have. And I've seen one dramatic perineal tendonitis that was just an inflamed tendon where somebody stuck the scope in the sheath and then put the probe up and hit the energy, and that reddened, inflamed, beefy tendinopathy just turned white under my eyes. And there's a Dr. Sussman up in New York, or maybe Pennsylvania. But regardless, I think he's done about 20 perineals, and he says it's one of his best indications. So there are skilled users that have expanded the indications. Our research has been on diseased and degenerated tendons, not inflamed tendon sheaths. But anecdotally, I am told by a number of people that it works on those too. So the only thing I'd say is if you're doing that, document it, because we really would like to document our outcomes and not just say it works on everything. So if you're using it and you've got the ability to document it, get in touch with me and we can talk about it. I'd be very interested in that. Is anyone doing the procedure in the office? Well, the Singapore study we did was in the office, and I'll tell you where it's going to be done in the office. If you're working like for a Kaiser or Geisinger, or working in a system where the insurer and the provider is the same basic umbrella company, then it doesn't matter where you do them. And so you want to do them in the lowest cost environment. You can do them in an office all day long. Like I say, we did 20 of them in Singapore in an examining room. So it doesn't matter. The reason they're done in an ambulatory surgical center in America is because that's where the best reimbursement for the facility fee is. And that's what pays for the, by the way, the probe is disposable. That's what pays for the disposable probe. If working on a cadaver or a calcific rotator cuff, you mentioned this could take up 7-8 minutes. If you had a large calcif that is taking longer, do you have absolute cutting times you won't go over? No, we've done experimentally in the office. I mean, we've run this thing for a half an hour and then tested it, and it seems to keep its energy up and doesn't deteriorate. And interestingly enough, for reasons that surprised me, the probe does not appear to be more brittle if you keep it going that long. So yeah, I think you can take as much time as it takes to do the job. What you might notice using the TX2, the longer you go, the handpiece will warm up some. I mean, it won't get real hot, but you will feel that it's warm. But right now, all of our data suggests you can keep using it until you get the job done. I actually just don't have experience doing that. In general, when I have done a procedure, like an arthroscopic procedure, even an open procedure, and I'm not worried about the healing of the wound, and I'm trying to calm down the inflammatory process, I will do a cortisone injection, and I kind of like to do those. However, in this setting where if you're doing a calcific rotator cuff tear, you'll remove all the calcium deposit. I'm not too worried about healing, and I personally don't see a problem with bathing that area in cortisone with local anesthesia. And I usually use a ratio of a 4-to-1 ratio of 0.5% Marcaine and Depomedrol in my injections. Pretty dilute, but I think it's reasonably effective. And so that's probably what I would do. With diffuse cuff tendinopathy, how do you pick which tendons to target? I would go clinically, which tendon seems to be most symptomatic. And this, of course, gets pretty tricky because if the person has a tendinopathy, well, I've told you I redid about 10 of mine. About half of those, I am sure, were progression of disease because when I did the ultrasound, it was in a different part of the tendon where they were having their hypoechoic area and where they're having their problems. So it wasn't the first one failed, it's just the disease process continued. So to avoid doing too much, I guess I would I just go where the tendon that is most symptomatic or that had the largest lesion that was symptomatic, that combination of those two. And so we can talk maybe more about that also if you're interested. What we're told, and John, once again, you may jump in here, but we explored an office reimbursement some time ago. And one of the important issues with the office procedure wasn't so much the efficacy, but was just more of a safety issue. And so the problem right now is, as we've explored this, office reimbursement just will not pay for the probe. And it's the facility fee that pays for the probe. The service, your professional fee is pretty well compensated. but it's the facility fee that is the deficiency, and that's what causes problems with reimbursement. John, anything you want to add to that?
No, I think you handled the statement correctly. I think the clarity is that insurance does pay for in-office use. It just simply pays the procedure or the professional fee only, where the facility fee is so small to be de minimis and such that it doesn't make sense from a facility's perspective to purchase the probe on the physician's behalf. So, and the answer is if we did seek clinical code specific or a code that's for use in a clinical environment, the likelihood is it would be a reduced reimbursement. That's correct.
Which procedures do you aspirate? Well, you should put the aspirate on all procedures. It's not after cutting you aspirate, so you should have aspirate and cutting on at the same time because it's a concurrent event. It's part of the procedure. And we usually use the medium settings for those on and irrigation. So aspiration, irrigation, and cutting all occur at the same time. I use medium for soft tissue, and you can put aspiration on high if you're worried about swelling. But if you're using if the diagnosis or you're using the probe on calcific tissue, then you put it on high. So real hard, dense tissue or calcific tissue, put it on high. Otherwise, I use medium. I love plantar fascia going with the short axis because I put the sensor on the long axis of the plantar fascia, and I can see it very, very well. It's just perfect. And then you can't miss your probe if you go short axis because it's going to penetrate the plane of the signal like a dot. So you can be very, very precise on that plantar fascia and get it right over the medial tubercle of the calcaneus. And then when you want to make sure you've gone all the way across, then I go long axis across the heel, but long axis with my probe, and I'm short axis with my pathology. So plantar fascia is long axis pathology, short axis probe, and then I flip them in. So I use both axes when I'm doing plantar fascia. Otherwise, I use a long axis with probe and with the sensor. When do you use coag? When I'm doing an open procedure. I don't do it with it's on the console, but it's disconnected. So you can't coag using the Tenex procedure. The answer is I haven't thought of it. Maybe it's a good idea. Sometimes patients will get a fair amount of swelling and others won't get hardly any. And I guess if you feel like there's a lot of swelling, you can try, but this swelling is interstitial. It's not free fluid. And I think more aspiration isn't going to do much. And saline resorbs so quickly. I just don't pay any attention to it. I mean, I'm used to a lot of swelling around elbow arthroscopy, and that thing was, and like you'd worry about even nerve or vascular compression, and it never happens. So even bad swelling resorbs quickly when it's a physiologic saline. So I don't pay too much attention. The surveys and talking to people around that are using this more and more on that, the smallest is probably 3, shortest is about 3 minutes, maybe 4. That would be more of a pasty, smaller lesion. And then it's gone up to 10 minutes. So it can be pretty long. I don't necessarily hold them before the procedure because if people are hurting enough to require this intervention, then I think it's okay to take those. Afterwards, I allow them as needed. We will use Tylenol as our pain medication, but I don't feel as strongly about the data on the effects of NSAIDs on healing. And so if a person says they have good response and they're still having symptoms, I will allow them to use NSAIDs, even though I recommend Tylenol and prefer Tylenol. If you are going to hold them, I would hold them for about 3 weeks. I'll give a broad suggestion, and then John, if you're on, you can certainly enhance what I'm going to say. But we have been working pretty hard on this. We had a consultant that helped us, And we've learned a few things. And the first thing is your dictation should be descriptive of what you do. It should be completely void of any reference to Tenex. That should never be uttered. Even the use of the term ultrasonic treatment, ultrasonic energy to treat, you can say you use ultrasonic guidance, but that's the only time you should use the term ultrasound. Um, and then you just describe what's done. And instead of saying a puncture site, we say a small incision is made. And I like to say and recommend, and it's carried through the subcutaneous tissue and through the fascia, because that's what I do. And so just describe what's actually being done. And then we say we've introduced the instrument, not the ultrasonic instrument, not the TX1 for goodness sake, into the pathologic area, and the area was treated by removing the diseased tissue. So those kind of generic terms are recommended. The the issue of coding is kind of a tricky one. One very, very important thing to recognize is that if your coders indicate that they're following the AMA guidelines, the AMA has officially said that they do not accept this as percutaneous anatomy and recommend a non-scheduled code or an unlisted code. The reality is the AMA guidelines are not legally binding. And I've talked to the people at the Mayo Clinic about it, and they confirm that if they have situations where they feel as though the AMA guidance is not accurate, then they follow their own judgment. And they do that based on the data. And what's the data? What kind of clinical information do you have to justify the use? And then what's been your outcomes? So those are some of the thoughts. John, are you on? Are you able to unmute and maybe provide additional comments?
I am, Dr. Morrey. The additional comments that I would make would be that each instance of challenge is very unique and can be not only tracked to physician dictation, but can also be tracked specifically to not only the third-party payer involved, but the health plan that the patient is on. So it's difficult to make generic statements. I think you did an excellent job of giving the company's advice, which is that the clinician is under no obligation whatsoever to describe the brand of the instrument used to complete the procedure. You wouldn't indicate what type of scalpel you used, except, and you certainly don't have to indicate the brand of instruments to complete the tenotomy. So I would say that the best course of action for anyone is, if there is issues and challenges, if there are issues and challenges, is a direct connection and a direct contact with us at reimbursement@tenexhealth.com. It's what I do. It's the task that I've been given, and I'm responsive to the emails. And not only that, but a lot of the information can be better delivered in a conference call setting, where I can have a good understanding of the clinician along with their support staff as to whether or not and what the challenges that they're experiencing. So I would just encourage reimbursement@tenexhealth.com and get me connected with your challenges directly. The answer is yes. So each of the distribution partners that we have and each of our regional sales managers have access to the reimbursement documentation that we provide, which is 4 specific documents. It's a pre-authorization template, of dictation template, verbiage, suggestions, guidance document on the CPT codes that we see used in the US today, and then a peer-to-peer talking points document for any kind of a intervention where a clinician needs to have a one-on-one conversation with a third-party payer. So those 4 documents represent our reimbursement documents. Again, if you need them, the best way to get them is reimbursement@tenexhealth.com, or ask a distribution partner or regional sales manager.
One of our best users is in the Oakland area, Tom Durick, and he is outstanding. He has a great experience. He's a pain doc. Pain docs tend to be, as you may know, anesthesiologists. The characteristics of the pain doc is they're very good at ultrasound because they block nerves, and most pain docs deal with neurogenic pain. There's a subset that do deal with musculoskeletal pain, And so there are some pain docs that actually use this a lot, and they use it in all anatomic areas. The key for these doctors is what's the nature of their practice and what's the nature of their referral practice. In other words, who's sending them what kind of patients. But if a person is in fact a pain doc, they need very little training. All they need really is the referrals. And that kind of is, it ends up being a local type of issue. I tend to double the time of allowing patients with patella tendinopathy to return to sport. So instead of thinking that they can resume activities by 3 months, I usually am holding them back till 5 or 6 months. It depends on how big the lesion is for a patella tendon. Of all the things we treat, the one thing that you just never, ever, ever want to have happen is to have a ruptured Achilles tendon. I'm sorry, a patella tendon, because all the other tendons you can handle. Achilles tendons rupture all the time, and patients do pretty well just with casting, as everybody would know. But patella tendon ends the career. I mean, I've had patella ruptures that I've had to try to fix, and I'd fix them, but they're never the same. So you do not want to be either responsible or felt to be responsible for it. So I go slow with the patella tendons, and if they're at pain at rest, then I don't cast them, but I put them on crutches, and I do advise them to be very careful about going upstairs, etc. If they're not pain at rest, then I don't think they're at any particular danger of spontaneous rupture. Remember, this is a common asked question. Remember, the energy of this removes diseased tissue that doesn't have any, is not contributing to any mechanical stability or strength of the system. So you're not taking down normal collagen fibers. So when you're done with your procedure, at least in my opinion, that knee is no more weak than when you started. With an Achilles insertionitis, the only ruptures we've had have been at the Achilles. One is an insertion, and 2 have been substance. One person fell down a flight of stairs in Alaska. I have no idea what he was doing there. I didn't even know they had 2-story homes there. But I don't know if the event caused that or what. But I do think that if they're really pretty tender, to put them in a boot would probably be a wise thing to do. Is there any interest in other sites to contribute to the clinical studies that are ongoing, particularly interstitial tears of rotator cuff? I would sell my oldest child almost to do that. That's not true, of course, but yeah, this is one area we would really like to explore, because there is no good treatment for tendinopathy, interstitial tendinopathy of the shoulder. And it's a very major problem for us. And for that reason, any intervention that is felt to be of some value is certainly worthy of consideration. And we have been discussing this, and I have done a survey of some of the guys that are using it for the shoulder. They have very large shoulder practices. And they do indicate that they have had good results with interstitial tears. So I do think that that is a reasonable indication, and I would even encourage people to consider it, and even more so to develop a study and to study it objectively. We're much more interested in scientific contributions, if you will, rather than just anecdotal. So yes, I think application of Tenex for interstitial studies is a very good indication, and I would encourage anybody that is on the webinar that is interested in anatomic areas to contact me, and I'm happy to try to help them design their study if they're not in an academic center, so or help them in any way that they may wish. So thanks for the question. That's a good, interesting question. We've developed a matrix. There's 3 things you really need, I think, to have a successful practice. The first is the volume of patients. So who has the volume of patients? Non-op sports. That's what they do. The second is who does, or what's your comfort level with ultrasound, because you don't want to be afraid of using it, and you don't want to necessarily have to learn a new technique. And non-op sports do ultrasound. The third is where you're going to do these. And unfortunately, the reimbursement model in the United States requires that you be in an ambulatory surgical center to get the maximum reimbursement. So if you look at those three variables, who has the high volume, who is comfortable with ultrasound, and who has access to a facility, there's no specialty that has all three of those in kind of 3 pluses. Orthopedic surgeons have a moderate volume of tendinopathy, but they prefer to send it out so that they can be in the operating room. They typically don't like ultrasound, including myself, at least before I got involved with this. They can get to the ambulatory surgical center because they typically own these. The other category, the non-op sports, they have high volume. They know how to do ultrasound. They don't have privileges typically, special arrangement. The third is the podiatrist. Podiatrists see tons of tendinopathy for sure, but they don't get into the ambulatory care facilities owned by physicians typically, and they don't teach ultrasound in their curriculum, so that whether or not they do ultrasound is kind of variable. And then when it comes to pain and interventional radiologists, both are great with ultrasound, both have facilities, but they don't have a stream of patients unless they develop some relationships. So the 5 treatment groups that we kind of recognize as being the group that is interested in what we're doing are, there's none of them that are absolutely perfect. For us, the group that probably is most effective is the non-op sports, because again, they have the highest volume and they have a tremendous skill and facility with ultrasound, and don't need to be trained in that. Question: what would hesitate a medical professional from latching onto this technique? I don't want to be flippant, but I'd say they haven't been exposed to it. For anybody that is listening or that's on the webinar, if you are a clinician, in my experience, the bane of my existence was chronic refractory tendinopathy. I did sports for 19 years and I did foot for 7 years. So I hated plantar fasciitis because I didn't know how to treat it and I didn't want to operate on it. I hated jumper's knees because I was worried about a rupture and they did not necessarily respond to local injections or cortisone. And when I waited it out and gave them time and they couldn't play and they couldn't participate, they didn't necessarily heal. So it seems to me that if you've got a very safe and very effective way of treating chronic refractory tendinopathy, and if that's an integral part of your practice, then I would be all over this for some other methodology like this. And in fact, I've told many of my orthopedic colleagues that when I'm seeing a patient and they come to me for help, I personally do not want to send them down the road to have somebody else treat them. I want to be the one to treat them. So I would want to learn this technology even as a surgeon. And at Mayo, when I'm doing these, I see my patients on a floor, 14th floor. And then during lunch hour, I'll go up to the cast room and do my Tenex cases. And I do them myself. We've done about 500. And I do them myself. Under local anesthesia, and I can usually do 3 during the noon hour. So that's an easy technique. But I want to be responsible for their care, and I want to be responsible for them getting over their condition. So, I really, the reason I got involved is because it appeared so attractive that I wanted to participate in understanding it, developing it, and then disseminating it. Sadly, it's an artificial distinction based on what your the basis of your revenue. The Singapore study, those 20 patients were all done in a clinical examining room where there was a desk and just an examining table. There was no special anything. Just one of the clinical staff was the assistant to help us do those. So I know you can do them in an examining room. But in the United States, the reimbursement criteria are the facility fees are greater if you're an ambulatory surgical center affiliated with a hospital. After that, an ambulatory surgical center independent. radiology treatment rooms, pain center rooms, and then in a clinical setting. And there's a different reimbursement schedule for those different environments. So unfortunately, and I feel bad about this because I think it's a game and I don't think it's a legitimate game, but you have to pick where you can have the probe paid for as to where you do these. That in the United States is in an ambulatory surgical center. That's why I was saying earlier, the right specialty to be doing this is the one that can get into an ambulatory surgical center, and it doesn't take such a long time to get approval. And it's so complicated to get approval, or you're already in the ambulatory surgical center. As an aside, the other thing that I would emphasize is if you're going to go into an ambulatory surgical center, and it's a real busy ambulatory surgical center, you talk to your anesthesiologist and do them in their block room. They still get the same reimbursement, and they already have the ultrasound machine there, so you don't have to invest in that. And they can even help you a little bit if you don't feel too comfortable finding or using the ultrasound. They can certainly help you with the adjustments. And the block rooms, as you know, are not used. The percentage of them actually being used is very low because all the time is spent in the OR, not in the block room. So I think that if I was running things in an ambulatory surgical center, I would schedule them with my anesthesiologist in a way that I would do them all in the block rooms.